may have significant difficulty accessing timely care. Today, we have some of our healthcare community members with us to help describe the situation for you. And while COVID cases and hospitalizations are rising, this capacity crisis is being driven largely by non-COVID factors. One of the greatest of those factors is patients who are in the hospital and cannot get out of the hospital. Across the state, between 10 and 20% of hospital capacity is being taken by people who no longer need hospital care. They're stuck and they're waiting to be moved into a nursing home, long-term care, or other long-term post-acute care setting. The patients that are stuck in these hospitals are tying up thousands of nurses and other staff members who should be taking care of patients who have acute care needs. It is also significantly delaying both emergent and scheduled healthcare services, particularly in our hospitals, providing the highest level of specialty and trauma services. One of these patients can take up an acute care bed for weeks or months, but in a typical case of an acute care patient, the stay is 3 to 5 days. And from a practical standpoint, what that means is that one stuck patient prevents a large number of acute care patients from getting the services that they need. This is also terrible for the patients who are stuck in the hospitals. These folks need to be in nursing homes or adult family homes or receiving home care services. When they are stuck in hospitals, they're unable to go outside or socialize with others, or have the kind of quality of life that they really need and deserve. Hospitals provide vital short-term acute care services, and they are not places for people without the need for acute care services to be for weeks and months, and in some cases, years. We have solutions that we know will decant the system, and we need to make sure that these strategies are being deployed as quickly as they can be to support the acute care part of the healthcare system so that folks can get the care that they need when they need it. And we're going to share those strategies with you over the course of this briefing, as well as what individual community members can do right now to seek care appropriately and help keep pressure off of the system. We are cautiously optimistic as of this morning that some of the there is some progress that is being made on some of our requests to the state government for help. It is the state government that is in a position to decompress the system by implementing some of the strategies that we are going to talk about. And we've heard some initial indications that progress may be made in the days and weeks to come. But right now we want to get our panelists in front of you to describe what it's like out there and what we need to have happen immediately to take pressure off of the system. We will hear from Dr. Steve Mitchell, who's the medical director of the Washington Medical Coordination Center, Christy Carrington, who is the Puget Sound Regional Chief Nursing Officer for Providence Swedish, Sommer Kleweno-Walley, who is the Chief Executive Officer for UW Medicine's Harborview Medical Center, David O'Brien, who is the Senior Vice President and Chief Executive for Multicare's South Sound region, Chief Steve Brooks, who is the Fire Chief for the City of Lacey Fire Department and the current President of the Washington State Fires Chief Association, Dr. Nathan Schlicker, who is the immediate past President of the Washington State Medical Association and a practicing emergency department physician, and Alyssa Odegaard, who is the Vice President of Public Policy with Leading Age Washington. So we have quite a lineup for you this morning, and we want to make sure that we have time for you to hear from each of our panelists. We're going to hear from Dr. Mitchell first, and I will just note that Dr. Mitchell is also actively working in the emergency department this morning. He is going to give our briefing, and then he will need to leave so he can go take care of patients. There is a lot of activity that needs his attention this morning. So Dr. Mitchell, I will turn it over to you.
Good morning. Thank you, Taya. So the Washington Medical Coordination Center works to load balance hospital resources throughout the state of Washington and hopefully assure that patients are able to access hospital services if they aren't provided at the hospital that the patient originally presented to. This usually involves moving a patient from a smaller and more rural hospital to a larger and more urban hospital, which has both the specialty equipment as well as the nurses and the doctors to meet each patient's needs. In the past year, the Washington Medical Coordination Center has fielded over 4,500 requests for assistance from hospitals in our state when they haven't been able to provide those services, and they've been unable to find a hospital, to locate a hospital with the resources to care for their patients. Nearly 75% of those requests have come from rural hospitals throughout our state. Our most challenging periods at the WMCC, the Washington Medical Coordination Center, have been during the patient surges related to both the Delta variant of last summer and then the Omicron surge of last winter. Unfortunately, we have returned to the same level, in some cases worse level, of both challenge and strain in our hospitals as we experienced during the periods of those specific surges related to those variants. Though COVID cases in our hospitals are on the increase, they are not close to what we experienced with prior COVID surges. However, we are very concerned about the new variants that are happening and the increasing community spread, but our challenge this time is not as directly related to COVID. Rather, this time, our challenge is because of two primary issues, some of which Taya has already mentioned. One, the lack of people to staff our hospitals, primarily nurses, medical assistants, technicians, and environmental services, really the lifeblood of our hospitals, which allow us to do the work of providing care to those who are in need. And because of that, in short, the number of beds which hospitals can staff has declined, just as our community's need for hospital care continues to escalate and increase. And two, the continuing challenge of being able to transition patients in our hospitals that Taya mentioned that no longer need to be in the hospital into those long-term or post-acute care facilities, such as skilled nursing facilities or nursing homes, who are themselves experiencing significant shortages of staff and resources. This severe strain is being experienced throughout the entire continuum of healthcare and across the state, and we see this from ambulances and paramedic units that respond to 911 calls that you'll hear about more in a moment, to overcrowded emergency departments where I work, to patients in our hospitals being taken care of in hallways and in classrooms that some of the other panelists may discuss as well. We are doing our best, but many of our hospitals, especially on the west side of our state in the populated areas of King, Pierce, and Snohomish counties, are more strained today than really at any other point since the pandemic began. This in turn limits our ability to get patients who arrive at rural hospitals originally that occur all over our state to those resource hospitals with the capability and the capacity to meet their needs. Though we always want the public to come to the hospital when you are sick and you need help, and we will help you, right now the helpers are they themselves asking for help. Thank you very much for the chance to address you this morning.
Thank you very much. Appreciate that, Dr. Mitchell. And now I'd like to have us turn to Christy Carrington.
Thanks, Taya. And good morning, everybody. It is really great to be here with you this morning, and so appreciate you taking the time to hear us. I'm Christy Harrington. I'm the Regional Chief Nursing Officer for the Puget Sound for Providence Swedish. I'm grateful to be here. So I do want to just carry forward a point that I know that you've been hearing throughout this conversation around some of these patients that we continue to have in our hospitals that are taking up capacity. I think as Dr. Mitchell so eloquently pointed out, we have the staffing component, which is a huge factor, but we also have a large portion of our patients, and for us at Providence Swedish, it's about 17% of our patient census consists of patients who no longer require hospital care. So these patients who aren't sick enough to require hospitalization, but we really are challenged with being able to find an appropriate place for them to go within the community. And these patients, as they're here with us for months and months, and in some cases even beyond a year, they require the same level of care and resources that any acute care patient in our hospitals require. So they still need the room, they still need the bed, They still need the nursing care. We treat them the same as we do any one of our other patients. And furthermore, the environment within the hospital is really not designed to care for these people who need that long-term care. It's not the best setting for them to have that healing care. They're not able to go outside or have those same types of activities that they would be able to have in a different type of post-acute facility. So these are some of the things that we're not able to provide to these patients that they do need. And this is a huge impact to us, of course, in our capacity, as I pointed out. But where we really need the help is really addressing some of the barriers that we have with getting these patients out of the hospital and to their next site of care within the community. One thing I'll also just point out, and I know that this is something that has been in discussion before, is one portion of those patients that tend to sit in our hospitals, they tend to be waiting for a guardian or appointment of a guardian because they don't have somebody who's appointed to be able to make those decisions for them for their next site of care. And for us at Providence Swedish, we see that being somewhere around, like I said, about 20% of our patients, of those long length of stay patients that require this type of support. And the problem really became a lot bigger when our state guardianship rules began requiring anybody who is wishing to transfer their loved one to a care setting out of the hospital to have power of attorney over that person. These are the same decision makers who we allow to consent to surgeries for these patients, for their loved ones, for do not resuscitate orders, or even make decisions about withdrawal of care for their loved one or their family members. But we don't allow them to make decisions on behalf of their loved one to transfer them to a long-term care home or to other skilled nursing facilities. And this is one thing that I would say would be really helpful to us, is to change how we interpret and apply our state guardianship rules so that we're not creating unnecessary barriers for us to move patients out of the hospital into a more appropriate care setting. So I think this is a really important point, because this is one of the things that we are challenged with in the hospital setting, in being able to help create more capacity, which of course limits our ability then to be able to have the capacity to support some of the more rural hospitals as their transferring needs are becoming more and more increased, as Dr. Mitchell pointed out. Thank you, and Taya, I'll turn it back to you.
All right, thank you, Kristy. And I would like to just point out on the point that Kristy made with respect to our state's guardianship law that requires a guardian to make decisions about moving a patient into long-term care when they have a perfectly willing and able family member standing by who is authorized to consent to every other healthcare treatment. We are unique in the nation in taking this position, in our state taking this position about the required appointment of a guardian, and we are feeling that pain across our healthcare system. It is not a practical way to move patients through the system that these folks all require a guardian, and we really implore that the state rethink its interpretation of this law, because it is unique and is creating unique backups and barriers in Washington state. Okay, so with that, I want to go ahead and turn it over to Sommer Kleweno-Walley.
Thank you. Good morning, everyone, and thank you for taking the time to be with us this morning. My name is Sommer Kleweno-Walley, and I am the Chief Executive Officer at Harborview Medical Center and also a Senior Leader at UW Medicine. UW Medicine includes not only Harborview Medical Center, but also UW Medical Center, which has 2 campuses, Northwest and Montlake, along with Valley Medical Center. Today, I want to really take a moment before I talk about the strain and stress to thank the staff and the providers that are at Harborview and are throughout the rest of UW Medicine. What they are enduring right now and what they come to work and do every day is nothing short of a miracle. And I have never been more humbled to be a part of this type of a team. The level of stress and the level of impact these providers and these staff endure every day is truly commendable. And I really hope that as a public, we can continue to support them in everything they're doing to ensure that we have adequate capacity. So Harborview Medical Center, along with UW Medicine, is experiencing record high inpatient census levels. Like my colleague, Dr. Steve Mitchell, who is currently working in Harborview's emergency department, we have not been under this level of stress at any point during the pandemic. This is unprecedented at this point. And as he said, this is not due to COVID per se. This is because of a very large impact of long length of stay patients on our inpatient census. At Harborview Medical Center, we are over capacity by about 130%. A good deal of these patients, well over 100, are actually fit into that category where they no longer need inpatient medical care. They do not need the care and the unique expertise of those individuals who work at Harborview, who are here to serve the most critically ill and the trauma patients. They would be much better served within a post-acute care facility, like a skilled nursing facility or a long-term care facility with custodial beds or adult family homes. Unfortunately, at this point, the capacity in those settings is not adequate for us to move those patients into those different facilities. And therefore, we are under very unique and unprecedented challenges to not only care for the influx that Harborview has of trauma patients and critical care patients, particularly during the warm weather months. We are also trying to balance caring for those individuals who really don't need the unique experience or the unique expertise of Harborview. Harborview serves a very special mission, and we are incredibly dedicated to ensuring that we remain stable and ready to take care of the public and to take care of the trauma and the critical care that is needed. However, at this point, we are asking for help, and we're asking for help to ensure we can continue to do that. We are working very closely with elected officials and have had very good discussions with both at the county level with our executive, Dow Constantine's office, and the governor's office on solutions that work towards ensuring that there is adequate post-acute care capacity in the future, and also to ensure that staffing gets put in to help maintain and keep the high quality and safety that we are committed to providing. We are caring for individuals in very unconventional places within hospitals right now. However, hospitals are very dedicated to ensuring that the quality and safety remain the same. We do that through ensuring staffing for each patient at the right level. We also do that through ensuring we have the medical equipment and other things that we need in order to provide that care despite the location within the hospital walls. People count on us to be there, and we will be there for the community, but at this point, we need help moving individuals into post-acute care settings so we can focus on the unique population that Harborview serves and that UW Medicine serves, the most critically ill, the trauma patients. Thank you very much.
Thank you, Sommer. And I think you all heard a really strong plea for care and help for the caregivers that are there to help our community members when they most need it. So appreciate that perspective. And now I want to go ahead and turn it over to Dr. David O'Brien.
Thank you, and good morning, everybody. It's my honor to serve as the Chief Executive for Multicare South Sound region. And I also want to express my gratitude, appreciation, and admiration to all the frontline providers for their commitment to caring for our patients and communities under these really unprecedented and very, very challenging times. And our healthcare industry is facing significant challenges on many fronts. But right now, we're really talking about our ability to meet the demand for inpatient care. Now, all of Multicare's adult hospitals have been operating at over 100% capacity for months. We're seeing that in the Puget Sound region, but we're also seeing that in our inland Northwest hospitals over in the Spokane area. When a hospital runs at over 100% capacity, 120, 130% capacity, it creates tremendous strain on the organization. Typically, you try to keep your capacity a little under 100%, so there's some room to move patients around as they transition from inpatient to outpatient or to discharge. When you're at 100+% capacity, it means you're taking care of patients in hallways and in other non-typical locations. And it creates a lot of operational challenges for our clinical staff as well as our administrative staff. As Dr. Mitchell and others have mentioned, really the demand today has some COVID component, but this is largely demand for just general medical care. It's not being driven by a COVID surge. And we seem to be seeing more sicker patients that need access to these inpatient beds. At our larger hospitals, for example, Tacoma General, Good Samaritan, and Auburn, as well as Deaconess over in Spokane, we've been working very diligently to accept patient transfers from other hospitals that are also facing capacity issues, and in particular, some of the smaller rural critical access hospitals that need access to higher level of care. So at this time, we have about 180 patients in our hospitals that have no need to occupy an acute care bed. In some of our larger hospitals, up to 20% of our beds are occupied by what we call these difficult to discharge patients. And so these patients are occupying a bed that someone else has an acute need for. And this can lead to delays in care for patients that are having heart attacks or strokes or other acute conditions. We're aware that our colleagues who operate skilled nursing facilities and some of the other post-acute care services have had impacts in their ability to accept our patients. And this just creates more and more challenges for us to discharge patients. I like to think of the emergency room as our front door and our post-acute care services as our back door. And when the back door is congested and closed, it makes it very difficult to keep the front door open. And so this creates what we call a longer length of stay. And this it really impacts our ability to admit new patients. And it's also severely impacting our financial performance. One of our biggest challenges is staffing issues. We have seen thousands of nurses and other healthcare providers leave the healthcare field, and we don't have an adequate pipeline to replace these professionals. And so to ensure that we have the caregivers we need, we have brought in temporary staff. We typically call them travelers. Right now we have over 1,000 travelers in our system filling these positions. And this temporary staffing comes at a financial premium that has significantly increased our labor costs dramatically. And other healthcare industries are like other industries are being affected by inflation. Our cost of supplies have really risen. And interestingly, unlike other industries though, when our prices go up, we cannot just pass that on to the payers. So we are seeing some significant financial challenges. So far this year, MultiCare has lost about $300 million. So this is really an unsustainable situation where we are seeing increased demand, significant capacity issues that are being amplified by some of the financial challenges. The bottom line is, I think our health system, delivery system, like others across the state and the country, are really facing some major challenges. So I'll pause there and pass it off back to Taya.
Thank you, Dr. O'Brien. And just a couple of points that I want to quickly underscore. The first is what it looks like in hospitals for caregivers and patients when they are over capacity. Both Sommer and Dr. O'Brien spoke to this. When you have, patients who are in conference rooms or in non-traditional patient care areas, they may be sharing a bathroom with multiple other patients. You've got nurses who are trying to care for patients who may not have access to oxygen for those patients on the wall, or be able to have suction available to care for those patients. And so the monitors aren't set up to monitor vital signs the way that they typically would be. This is a really, really challenging environment in which to both work and receive care. And so just want to acknowledge, and folks in these hospitals are, those that need acute care are sick. You know, you're not in a hospital when you're feeling your best. And so this is a very, very challenging situation to both work and receive care right now. The other piece that Dr. O'Brien spoke to is the financial position of hospitals. I'll highlight this again at the end of our briefing, but the financial situation that hospitals are in right now is very precarious. And we will be having another briefing on that later this week, because these issues are all tied together. So this issue doesn't just affect hospitals, it affects the entire healthcare system. I want to go ahead and turn it over now to Chief Steve Brooks, who's the fire chief for the City of Lacey Fire Department and also the president for the Washington State Fire Chiefs Association. I think it's important that we have this additional perspective on the system.
Thank you, Taya. Thank you to the panelists for the invitation and the opportunity. I know at times it can be difficult to draw the nexus between how the fire and EMS community are impacted and how also we impact this problem. And so this is also helpful for me to hear the totality of the perspective and be able to take that back to my peers and colleagues. As was mentioned, my name is Steve Brooks, and I'm privileged to serve Lacey Fire District 3 in Thurston County, and as the president of the Washington Fire Chiefs representing the fire and EMS service statewide. And I will just echo what you've already heard from lots of the facilities and the physicians region-wide. We are certainly seeing this across our state as I talk to all of my colleagues, but obviously centric to the catchment areas where the rural or critical access hospitals are needing for transfer capacity and the opportunity to move patients to higher acuity settings. This need for the ability to pass through to post-acute care, I think, is one that honestly our industry is probably not as familiar with, the understanding of that lack of capacity. And so again, this is helpful. I want to offer the perspective on how these delays of the throughput process do create an impact on the fire and EMS community. And one of the largest issues that we're experiencing, I know in my region, and when I talk to my colleagues statewide, is just the time for transfer or offloading once patients actually arrive at an emergency department or other acute care setting. I think the record I've heard of in my community so far is about 4.5 hours where an ambulance crew or a paramedic unit was waiting in an emergency department for a receiving bed because literally all of the available beds were either taken up by higher acuity patients or by patients who were boarding in the emergency department because there was not inpatient capacity in the normal areas of the hospital. And in our region, we're seeing that routinely, that the entirety of the normal capacity of an emergency department is actually taken up by patients who would otherwise be in an inpatient room up on a floor. And that is becoming very common practice. Another element that I was not invited for, but I'll just share a personal anecdote, is I actually have a member of my immediate family who has a pretty severe chronic illness and requires acute care usually a couple of times a year. And just in our own situation over the past year, had a 3-day acute care stay in a hospital where never was able to leave the emergency department due to a lack of capacity in that facility. And had to receive care in the ER. And while the staff did the best they could and with due diligence in trying to make sure she was taken care of, the lack of ability was already mentioned by just things as simple as contact with the staff, the normal push call button that you take for granted in a regular room when you're in a hallway bed. Those things have not been thought about. Those impacts are very significant. But we recognize that when our units arrive at a hospital, we're standing either in the receiving area, or more often now even being told to wait inside the vehicles out in the receiving area for the ambulances. That is a throughput issue that creates stress on the staff inside trying to find capacity where those patients can be cared for. The opportunity for our crews to have adequate things as seemingly simplistic as oxygen capabilities. You know, our crews, our vehicles have limited capacity for onboard oxygen, and you can easily run through those if you're sitting with a patient out in a parking lot without the ability to receive that patient inside for periods of time. So the other one that I'll just mention that is on the backside of this is the predictability of staffing for the transport resources. Our community and others I know rely fairly heavily on private ambulance companies for both our 911 and our interfacility transfers. And lots of times they're relying on the same units to do 911 response as they are for interfacility or discharge transfers. And so when they are trying to predict their staffing levels, if they have a unit that is held up in a hospital ER for 1 to 3 hours of transfer time, that unit is missing multiple 911 calls. And so we are having increasingly routine experiences of no transport units available to come out and pick up the patients in their home or the other settings where we find them in the community. Our crews are trying to be creative and working with alternative methods of transport or even alternative destinations when we know that the hospitals are basically saturated or unable to receive. But that puts our personnel in those transport units in difficult positions of trying to make what we sometimes coin the least worst decision in a moment, because the hospital doesn't have capacity to receive you. We don't have a vehicle to transport you there, but you're obviously in distress. And so what do we do in that moment? So it's a whole new area of training and emphasis that we're having to work through with our personnel just to help them with those critical decision and triage points on how can we deal with normally acute care patients that there's no acute care accessibility for them in the moment. So again, we appreciate the opportunity to be heard on this and to be a part of the discussions and for a solution. And we'll look forward to listening to the rest of the panelists.
Thank you, Chief Brooks. Appreciate that additional perspective, and hope that y'all are hearing just how hard all folks all across our system are working to provide the best care they can under very challenging circumstances. There are way too many least bad decisions being made out there right now. So with that, I want to turn it over to Dr. Nathan Schlicker, and we will hear his perspective from the WSMA, the Washington State Medical Association, and in his role as an emergency department physician.
Well, thank you so much, Taya. Appreciate it, and really appreciate all the comments that have been made. I think Chief Brooks really highlighted it. It's that our whole system is overwhelmed and everything rolls downhill. And I often think of it as a practicing ER doc in the ER with me, but it even backs up into our ambulance bays. The challenge that we're seeing is that the system has returned, to the strain that we were under pre-COVID, and for a little while we had bought space, through a number of mechanisms, but we're back to that original strain, plus the strain of the ongoing COVID, plus the strain of 2 years of a pandemic that has really taxed our frontline personnel. And as has been mentioned by numerous panelists, staffing remains a challenge. At the end of the day, this is making the care environment a challenge to deliver in. I, as a practicing ER doc, used to bemoan working out of my hallways instead of my ER rooms. And now it's working out of my lobby instead of even my hallway beds. Our patients are struggling to get that care. And add to that a busy return to life that has introduced more trauma from things like fireworks, motor vehicle accidents, gun violence, et cetera. And we are seeing an increasing pressure on the system. And so I think the key message is here, we got to get folks out of the buildings, but when you come to see us too, I hope you'll have a moment of grace and patience for all those that are doing the tireless work to care for you, because at the end of the day, they are working in an non-ideal environment. They're working in places they don't want to work and they don't want to provide care for you, but they're doing the best they can in the moment, in the crisis, to care for you. And when you add to that a situation where people are frustrated and taking out their delays on the staff, it's going to only make the staffing crisis that we have today worse, because it's hard to go to work. It's hard to do this work in the hallways or in the lobbies or in a place where you don't feel like you have your best tools, but then to feel like despite all that hard work, the extra shifts, the hours on end, that people think they can just yell at you or take that out on you, as we're seeing right now in the media. I think that only makes our situation more challenging as we try to staff in the future. So I just implore folks, be safe when you're out there. Please take a moment to wear your life vest when you're swimming in the water when it's warm out, put your seatbelt on, take an Uber instead of drinking and driving. All those things to reduce that pressure on our health system. When you do come and see us, have that grace, as Chief Brooks demonstrated, you may end up spending all 3 days of your hospital stay in the ER, and we're going to do everything we can to care for you. But it's not going to be perfect, but we're going to do everything we can to give you the best care that's possible. And then on the legislative front, we need help from Olympia and from our leaders to get folks out of the building. Because if overnight, we got those 10 to 20% of folks that are staying in our buildings out of the buildings, our capacity would be a very different conversation. I might actually get to care for you in an ER bed again, not just the hallway. So join us in this fight. Let's all do our part, and we'll get the health system back up and running in a very successful way in the future. But continue to do the same thing, I think, is the definition of insanity.
Thank you, Dr. Schlicker, and appreciate that perspective that you offered, and just want to acknowledge the care that you yourself are providing day in and day out in the emergency department for members of our community. I am going to next pass it over to Alyssa, but before I do that, I want to build off of something that Dr. Schlicker said, which is that we do want and need help from state government in particular, and I want to highlight a few of the things that we need help on. So we mentioned already, I think Kristy mentioned, the need to stop the requirement that a guardian be appointed for Medicaid patients in particular to be able to place into long-term care. Our state is unique in that requirement. Kristy, can you just pop on here to say Providence Swedish operates in multiple states across the country. Are you aware of this being the case in any other state, this particular type of requirement?
I have not heard this in any other state other than here. I know we do hear this, of course, up and down the Puget Sound and across the state. But as I mentioned, we have about close to 300 patients, and about 20% of those patients are waiting on guardianship. So it's a big portion of what we have some control over.
Thank you so much. And as Dr. Schlicker pointed out, if we could move those patients out, we would be able to care for acute care patients in emergency department room beds and acute care beds again. Washington State is one of the states with the fewest number of beds per capita. We are ranked number 5 lowest, 5th lowest in the country for number of beds per capita. And so those beds are a precious resource, and we really need to protect them and make sound policy to keep those beds free. The other thing that we are asking for from the state is to fund what's called a Bed Readiness Programs. We're asking that the state pay for programs that hospitals are currently using to supplement for patients who no longer need care, to expand those programs. So they're programs that provide some additional payment for long-term care facilities to be able to accept those patients, or to be able to stand up those programs within hospitals and staff them with extra funding. And Sommer, I know that Harborview operates one of these bed readiness programs. Do you want to briefly just say how it works? And this is a strategy that we know will work in Washington State because it's already working at Harborview.
Yeah, thank you, Taya. One of the key components of the Bed Readiness Program is that many of these individuals who have long lengths of stay have behavioral and social economic components to their to them as individuals, which makes it more complicated for a post-acute care facility to take care of. So what we've done in Bed Readiness Programs is offered an additional enhanced payment that Harborview funds above and beyond what the managed programs provide. And that extra payment helps the post-acute care facilities, particularly those skilled nursing facilities, take on those more challenging individuals so they can get a little bit more reimbursement for it in order to care for those that have more social behavioral complex conditions. In addition, we provide some wraparound support from UW Medicine and Harborview, where we send in physicians and care management and social work to ensure we work on the throughput of those individuals. So when they're in the skilled nursing facility, when they're ready to go to a long-term care bed and move to different parts of their insurance structure, when they need to go on straight Medicaid, fee-for-service Medicaid, our Harborview care managers and social workers continue to follow and work with those individuals to ensure they move. And that allows skilled nursing facilities to feel more comfortable in order to take those patients, because they're not as worried about not being able to pay the bills if they don't get enough money to care for them. So it really is an enhanced payment model that helps the post-acute care facilities have the types of support and resources in order to take care of the more complicated population we're seeing that are part of this long length of stay issue.
Thank you very much. two other asks that we have of the state. The first is to expand rapid response teams to help stabilize long-term care facilities. We'll hear from Alyssa in just a moment, but we know that our long-term care partners are struggling to stay adequately staffed and resourced, and that COVID-19 has really created challenges for their facilities as well. And earlier during the pandemic, the Department of Social and Health Services contracted with a temporary staffing agency to provide rapid response teams to provide short-term staffing support. And that support really did help decant or move out some of these patients from acute care facilities into long-term care facilities. And it helped take pressure off of the system as a whole. And so we are really hoping that the state will go ahead and continue that type of a program. And finally, the last ask that we want to highlight this morning is we are asking the state to expand child and adult respite care capacity to help prevent inappropriate hospitalization of kids and adults who have developmental disabilities. This is a population that can be challenging to care for in the home. They often don't have acute care needs, or once their acute care needs are taken care of, they can be difficult to help move back into the community. And so we want to make sure that those who are community caregivers are supported in their caregiving for these individuals, because when these individuals do come into the acute care setting, it can be very, very challenging to transition them back to the community. So we want to make sure those who are in the community and caring for them get the support that they need. Okay, with that, I want to turn it over to our last very important panelist, Alyssa Odegaard, who is a great representative for our long-term care system. She's with Leading Age Washington.
Thank you for having me. Thanks, Taya. Again, Alyssa Odegaard, Vice President of Public Policy with Leading Age Washington, representing our state's long-term care providers. Hospitals have always been one of the largest sources of patient referrals for our skilled nursing setting, and it's our mission to provide care and services for older adults who need placement. But long-term care is facing a workforce crisis, as many have said. Some national studies have Washington as one of the top states for staffing shortages, with an estimated turnover for some positions being over 40% right now. Many of our facilities have vacant beds. Over half that we surveyed have at least 10 beds right now that they are unable to fill due to staffing shortages. Some of the larger facilities have as many as 50 open beds. They are unable to admit patients from hospitals because they cannot safely meet their needs without staff. Our staffing shortages have started long before COVID due to Medicaid underfunding, but it's gotten exponentially worse during the pandemic because our staff are burned out. Our workers require skill and compassion, yet their compensation does not reflect the difficulty of the job, so they're leaving the field for easier work and for better pay. We support these immediate short-term fixes, again, especially increasing our state's rapid response teams. These teams have been invaluable in filling the staffing gap and have assisted some communities needing immediate help to care for their residents and to assist in admitting patients from hospitals. They are especially helpful because most long-term care can no longer afford the private staffing agencies or traveling nurses. The need is so great for these rapid response teams that the requests do outnumber the available resources, leaving many communities with no help right now. We are thankful that the teams have continued, but we do need to grow this resource and ensure their availability while we work on hiring our own staff. We also agree with better addressing guardianship to help expedite patients getting out of hospitals. But we also need to be looking at long-term solutions if we are to truly turn around our staffing shortages and return to normal admission levels. This starts with Medicaid rates. Skilled nursing facilities rely on Medicaid for over 60% of their revenue. This last year, the legislature made great progress in increasing wages for our direct care workers for skilled nursing facilities, and will start to help increase those wages, as well as large investments into some of the other settings. But more still needs to be done. Because of our rate structure, our reimbursements for providers lag far behind the actual cost of care, especially during the last year when we've seen inflation skyrocket. Without adequate reimbursement, we are unable to pay our direct care workers livable wages. Our CNAs for both assisted living and skilled nursing facilities, average pay has been between $16 and $18 an hour. some of the lowest wages in the healthcare settings. And this is unacceptable. We will not start to rebuild our workforce until we pay those aging services professionals living wages and offer other incentives to attract qualified individuals into the field. We also need to be expanding training and advancement opportunities for this profession and to build a dependable pipeline of trained caregivers. Any advancements that we can make in funding and workforce solutions will help to repair and rebuild our long-term care system and to ensure our entire healthcare system is working as intended. And again, thank you very much for having me and allowing me to participate in this panel.
Alyssa, thank you so much for being with us today and to helping to represent the folks that are providing care in the long-term care system. It is hard work. And we need to make sure that those folks, as you say, are incentivized and supported in doing that work. Okay, we have now made our way through our panelists, and I want to go ahead and turn it over to anyone who has questions. We can have some Q&A and dialogue here.
And folks who have questions can either put them in the chat box, or you can go ahead and unmute yourself and ask them directly.
Yeah, I have a question. This is Jennifer Dowling with Channel 13 TV. So I wanted to check and see, like, so if I wanted to put my loved one in a care facility, would there be a barrier to that if I wasn't elected a guardian, or if I was a guardian, or what's the holdup? Like, if I wanted to put someone I know in a care facility?
Great question. So this is a scenario where we have someone who is an inpatient. You are an appointed decision maker for that individual, and they need to move into a long-term care facility. I'm going to ask Zosha Stanley on our staff, who's works a lot in this area and focuses on these barriers to talk through how that might go and where you might run into challenges.
Yeah, thanks, Taya. Good morning, everybody. So one of the challenges we think about, especially for Medicaid patients, so people who are Medicaid eligible based on income, and if they need to move into a long-term care setting, for that population of patients, even if, if I'm in the hospital and my husband is there and for some reason I don't have a power of attorney that I've done while I had capacity, if I lack capacity and I'm a Medicaid patient, I need long-term service and supports, my husband he can agree to my medical care while I'm in the hospital, but he couldn't agree to my transferring to an adult family home, assisted living facility, et cetera. The hospital would need to help appoint a guardian for me. So that probably would be my husband if he's willing, but that still requires many weeks, potentially months of me waiting in the hospital while a court process takes place for my husband to be appointed my guardian. So the way around that would be if I had a power of attorney already executed while I had capacity. But the other thing is that, for other types of patients who are not Medicaid patients, my husband could potentially, now if I had other types of insurance, if I had long-term care insurance, et cetera, he could consent to my movement. But if I'm a Medicaid patient, there's an additional barrier to me being able to move into the next better setting for me if I need long-term care. So Taya, anything you want to add to that?
This is Kathy Sauer. I'm the CEO of the association. I want to say, to use the example that Zosha just said about what her husband could consent to, Zosha's husband could consent to major surgery for Zosha, could consent to withdrawal of life support from Zosha, could take action that would end her life, cannot consent to her moving to a long-term care facility. That's part of what we're struggling with, is that it's quite wacky, the differential about what you can and can't consent to without a power of attorney. And most people don't have powers of attorney. Most people assume their spouse. It's a reasonable assumption that one spouse or adult child can make that kind of decision for them. So many people don't have that document in place because you have a spouse, you have a child who you entrusted to make those decisions, who's going to be there with you at the hospital. You don't think you need to execute another legal document to make that happen, especially if you've had them consenting to medical care for you multiple times, which is often the case for these patients.
Thank you, Zosha, and thank you, Cassie. It is an extremely frustrating dynamic that is being caused by this particular interpretation of state law. Getting a guardian appointed is a really big deal. It requires going to court and getting a court to take action is not an expedient way to move folks through the healthcare system. So again, we're really asking that the state re-examine its position so that we can take pressure off of our system. Okay, we've got some questions coming in through the chat. Question here about monkeypox. So monkeypox is newly emerging in the community. Comment here about the challenges that it is creating in New York. I'm gonna see if perhaps Dr. Schlicker is on, or maybe Dr. O'Brien, one of you could speak to this from your perspective as physicians.
Yeah, happy to. I think monkeypox is an issue that we're watching, obviously concerned in our community about what it will do. At this point, as has been talked about, capacities at, Harborview upwards of 130 to 140%. So even small numbers of cases matter, but we don't see it on the level of the COVID crisis at this time. I think there was another question in the chat about how our COVID case is doing in the system. And I would note that what we're seeing, in my practice is that COVID cases are going up, but they are not of the respiratory variety. We're not back to large ICU volumes of vented patients or those with primary respiratory presentations. What we're seeing is folks that have underlying health conditions, they're getting strained, much like we would see in a winter flu season with those that have COPD or heart failure or kidney disease, that are, it's just the last little domino falling that knocks things over and sends them to our facilities. So I think that's the takeaway, is that, in all this, is it's no longer a single item of, COVID respiratory pathology overwhelming our system. It's a death by 1,000 cuts. It is the small number of COVID patients that we are seeing. It is the 10 to 20% of the long-term stay patients that can be treated somewhere else. It's the potential of the 1 or 2 monkeypox cases down the road. But there's not a single, silver bullet. It's we need to tackle all of these issues together. Hope that answered your question.
Thank you. Okay, I have a question here about the problems are most acute in Western Washington, but wondering about cities impacted in Eastern Washington that are struggling with this, and impacts on rural hospitals. Are rural hospitals challenged to move patients to bigger urban facilities? And to that latter point, I will say yes, absolutely, they are. We are seeing rural hospitals need to hold patients longer than they typically would and care for a higher level acuity of patient than they typically would, trying to take some of the pressure off of the larger urban centers. But for some of our panelists who operate hospitals in not just Seattle, but other areas of the state, thinking about Kristy and Dr. O'Brien, can you give some perspective on other areas as well?
Sure, I'm happy to, and I'll also look to see if Dr. O'Brien has anything to add. Yeah, I think that, as you know, for Providence Swedish and Providence facilities in particular, we have locations also on the eastern side of the state. And, as we look at capacity across the state, I think we've been especially challenged in many of the same ways. And I think just to kind of allude earlier to a comment that I made earlier is, as the western side of the state becomes impacted, a lot of the facilities that require transfer for certain specialty care oftentimes comes from east to west, at least for us across the Puget Sound. And so a lot of times when we have these specialty service needs or perhaps higher level of care, that's where our limitations become constrained, particularly with the capacity and staffing challenges that we've had. Dr. O'Brien, anything else you'd like to add?
Yeah, what we've seen in the past is that the inland Northwest tends to lag a little bit behind what happens over in the Puget Sound. So when Puget Sound has a big COVID surge, it catches up to the inland Northwest. So at the moment, we're a little bit better off in our inland Northwest hospitals. We're in about 95% capacity. Just under 100% capacity in the last few days. And so that still puts us in the red zone for, efficient operation of a hospital, but it's a bit better, quite a bit better than the Puget Sound region hospitals. So, but we're, you know, we are routinely doing everything we can to accept transfers into the like Deaconess or Valley Hospital. We have there's quite a large number of critical access hospitals scattered throughout central and eastern Washington, and we're the Spokane area is often viewed as, you know, the higher level of care for those communities, and you know, our hospitals and our Providence colleagues, we accept those patients as best we can and provide support for those hospitals as well.
Thank you very much. We have a couple of questions here about difficult to discharge patients, acknowledging that, you know, you all have been hearing about difficult to discharge patients for months. We are tired of talking about this too. We have given our specific requests to the state. They are taking some steps. The biggest step, or one of the biggest steps that we know will help some number of our hospitals, is to change their position on the state guardianship law interpretation. This could mean that the state reviews legal briefing that has been provided to them on how the law can be interpreted and is interpreted in multiple other states. It also could mean a state legislative change. The Hospital Association, and with the support of other organizations, advanced legislation to clarify this law last legislative session. Unfortunately, it was not successful. That is a huge change that the state can make. The other thing that the state can do are the things that we were talking about earlier with strike teams to support long-term care services and these bed readiness programs. However, it really would make a big difference for there to be a policy change in the way the state is actually interpreting the law. So wanted to just speak to that. We also have a question for Chief Brooks about how some crews are working to, are trying to work with alternate method of transport and destinations. If you could speak to that.
Certainly, and again, this will be a bit regionalized in the approach, but I can just kind of summarize by saying, historically, if there was ever a question, we would always err on the side of caution of yes, the trip to the emergency department is your best option in this case. And now, part of what we always see our role as is education of the patient. And now it may be that when we're able to educate the wait times or the lack of capacity, perhaps either a telehealth option or contact with their private physician if they're available during hours, or we're also looking at opportunities for urgent care or freestanding emergency departments that don't have inpatient capabilities. The challenge there is that if that's the chosen route and then they get there and it's deemed that it's beyond the capacity of those, then we've basically created a second tier of response need, because now the transfer from that freestanding clinic or emergency department is required to the opportunity for acute care or inpatient treatment. So we're working on all those things. Again, telehealth is an option in certain regions, but not widely available. And many times it's challenging for our providers not to feel comfortable in leaving someone at home or having them basically sign against medical advice once they're informed or educated about the lack of capacity at a hospital. So those are kind of some highlights of the areas that we're working on with it. And hopefully we're going to find more and more of those opportunities. I know there are some communities that are even experimenting with deployment of mid-level providers alongside fire and EMS resources, so that there's potentially prescriptive capabilities actually on the crews who respond. But that's, again, funding challenges, and funding is also an issue for those transports to alternative destinations, because while we were given some statutory relief a couple of years ago about the ability to transport patients to urgent care facilities, many of the insurance providers will not cover those. There's not a level of medical necessity for ambulances when they transport to those. So they really battle to get funding when they choose those alternative destinations.
Thank you, Chief Brooks. And I think there may be a question or two that we did not get to, and we'll make sure that we follow up with you on those. But I want to honor time and wrap us up here. So I do want to acknowledge that a number of these panelists reference that the patients who are stuck in our hospitals are there because of multiple factors. We've talked about a lot of those. Staffing is one of them. Financial resources related to staffing is another very significant issue. And later this week, we are going to be holding a briefing specifically on the very precarious financial position of Washington hospitals. It is as bad as it has been in this generation. It is really unprecedented territory that hospitals are in from a financial standpoint. So prior to this, we wanted to make sure that we shared what's happening with you all on the capacity challenges, but we also really urge you to join us on Thursday so that you can hear about this dynamic, because it is going to have and is having a significant effect on access within our system. So this briefing is going to take place on Thursday at 11 a.m. We hope many of you will attend that, and we will send an invitation out for that later today. So thank you again. We really appreciate everyone's time. To our panelists, thank you very much. And please express your appreciation to all your staff for the hard work that they are doing out there. I think that's it for us today.
Thanks, all.